Welcome to XY Files podcast. I'm Vladimir Kotlov, MD, the founder of Vidma, with a medical background in urology and deep expertise in male hormone optimization and fertility. This is episode 17 of 18 in our low testosterone series. Last time we covered testosterone replacement therapy formulations, dosing, and what to expect. Today we're getting into when does TRT start working, timeline, and labs. The reason this episode matters is simple. Men usually ask the timing question too early and too vaguely. They want to know when they'll feel better, but they often have not confirmed the diagnosis properly. They have not classified the type of hypogonadism, and they are not clear on what better is supposed to mean. Libido is one timeline. Mood is another. Body composition is a longer game. Bone is slower still. If you expect all of it to change at once, you're going to think a good treatment failed, or worse, think a bad treatment worked. And remember what we talked about last time. Formulation changes the delivery pattern. It does not repeal human biology. You can change a blood level faster than you can rebuild a sex drive, improve recovery, reduce waist size, or restore bone density. Hormones are not espresso. One of the mistakes I see almost every week is a man coming in after he started treatment somewhere else, already frustrated, saying, "I've been on this for a few weeks and nothing happened." Then I look at the original workup and there was one afternoon total testosterone, no morning repeat, no free testosterone by a reliable method, and no LH or FSH. At that point, the timeline question is almost beside the point. We still don't know if the diagnosis was right. So let's start where timing actually starts, with diagnosis. Male hypogonadism is a clinical syndrome, not a lab number by itself, not symptoms by themselves. You need both persistent symptoms and biochemical evidence of deficiency. At Vidma, our decision thresholds are 350 nanograms per deciliter for total testosterone and 100 picograms per milliliter for free testosterone when symptoms persist. And I'll say it plainly because this gets lost in online conversations all the time. A low number alone is not a diagnosis. Symptoms alone are not enough either. The lab work matters just as much as the symptoms, and the right lab work matters even more. We want a morning blood draw, ideally between 7 and 11. We measure total testosterone by LC-MS-MS, and we prioritize free testosterone measured directly by equilibrium dialysis with LC-MS-MS. Most labs still lean heavily on immunoassays. They're common. They're not always precise enough for this problem. We do not rely on a guessed free testosterone calculation, and we do not need a separate SHBG test to estimate it, because equilibrium dialysis measures free testosterone directly. And alongside testosterone, LH and FSH are mandatory, not optional, mandatory. Without LH and FSH, you cannot tell whether the issue starts in the testes or higher up in the brain signaling. That distinction changes treatment. High LH plus low testosterone points to primary hypogonadism. The brain is already shouting and the testes are not responding. That usually points toward testosterone replacement. Low or normal LH plus low testosterone points to secondary hypogonadism. The signaling is weak. If LH is below 8 milli-international units per milliliter and the axis is otherwise intact, enclomiphene is often the right first-line treatment, especially in functional hypogonadism. I sometimes explain it like a thermostat and a furnace. If the thermostat is calling for heat and the house is still cold, the furnace is the problem. If the thermostat never calls, replacing the furnace is a strange place to start. Functional hypogonadism is the version we see most in the real world. No tumor, no structural damage, just an axis that is suppressed by obesity, metabolic syndrome, type 2 diabetes, poor sleep, medications, or a pileup of those things at once. In that setting, the system is often still capable of working. It just needs the signal restored. That is where enclomiphene makes a lot of sense. It stimulates the body's own production, preserves fertility, maintains testicular function, and generally carries a lower hematocrit risk than TRT. When I was a resident, I used to think that if you normalized the testosterone number, the case was mostly closed. I was wrong. Numbers matter, symptoms matter, classification matters, and timing only makes sense after all three line up. Now, if the diagnosis is correct, how fast does treatment work? With TRT, serum testosterone can rise quickly, but symptom improvement is slower and domain-specific. Sexual symptoms often begin improving by about 3 months. Mood and energy may shift earlier for some men, but the effect is usually modest at first. Body composition changes are typically more noticeable over many months, often closer to a year than a few weeks. Bone changes are the slowest. When bone monitoring is clinically indicated, we're thinking in terms of 18 to 24 months, not next month. Enclomiphene looks different. Because it works by blocking estrogen feedback at the hypothalamus, it increases GnRH, LH, and then testicular testosterone production. In men with secondary or functional hypogonadism, LH and testosterone often begin rising within 1 to 2 weeks. That early lab response is common. Clinical improvement still takes a little longer. Usually you're judging symptoms over roughly 4 to 12 weeks, not 4 to 12 days. That difference is important. A man may look at a quick lab rise on enclomiphene and expect an overnight transformation, not how it works. The endocrine system is adjusting. The downstream symptoms are catching up. Libido may move first. Morning erections may become more consistent. Recovery may improve. Mood may feel steadier. But it's a progression, not a cinematic montage. Last month, I saw a man in his early 30s who wanted future fertility, felt flat in the gym, had lower libido, and assumed testosterone injections were the fastest route because faster always sounds better. His LH was low, his free testosterone was low, and his testes were capable of responding. That is exactly the kind of situation where enclomiphene is often a better first move. Faster is not the only question. Appropriate is the question. And fertility changes the entire conversation. TRT suppresses gonadotropins and spermatogenesis. If you are actively trying to conceive, TRT is the wrong treatment. If you are not trying today, but you want to keep that option open, you still need to think ahead. Men often tell me, "I'll deal with fertility later." That can become a very annoying future project. Recovery of sperm production after TRT may require stopping TRT and using gonadotropin therapy, such as HCG plus FSH, for months, sometimes more than a year. Some men do not fully recover. If LH is below 8 and the axis is intact, enclomiphene often avoids that detour entirely. So what is realistic over the first year? The strongest and most consistent early improvements are sexual. That is what the better studies tend to show, and it fits what I see in clinic. Men may notice better libido, more frequent morning erections, improved sexual interest, and sometimes better erectile function within the first few months. By about 3 months, that is where I expect the clearest signal if treatment is genuinely helping. But there's an important nuance here. Testosterone can improve hormone-related sexual symptoms. It does not cure every cause of erectile dysfunction. If a man has significant vascular disease, neuropathy, medication effects, pelvic floor dysfunction, or a major psychological component, normalizing testosterone may help, but it may not finish the job. Sometimes the right answer is combined management. At Viedma, when erection or urinary symptoms are also part of the picture, the enclomiphene plus tadalafil combination tablet can be useful because you're addressing more than one mechanism at once. Mood and energy are more slippery. Some men feel steadier or more motivated within weeks. Others take a few months, and the effect is usually real but not dramatic. Testosterone is not a universal cure for burnout, sleep debt, overwork, or primary depressive illness. A good JAMA psychiatry meta-analysis showed improvement in depressive symptoms, but it was modest. That matches real life. If a man's mood remains poor after testosterone is normalized, I start looking harder at sleep apnea, psychiatric history, thyroid issues when indicated, alcohol, medications, and the broader life context. Body composition is slower, and this is where men can get impatient. A guy will say, "My scale didn't move much, so I guess this isn't working." The scale is not a very thoughtful witness. If you gain lean mass and lose fat, the scale may barely budge. Waist circumference, training capacity, recovery, and how your clothes fit often tell the story better. Over the first year, testosterone treatment can reduce fat mass and increase lean mass. That is real. It just does not happen on the same clock as libido. I've had plenty of men tell me the first sign was not the mirror. It was that squats stopped feeling like a tax audit, or they stopped needing 3 days to recover from a reasonable workout. That kind of change matters. It is also easier to miss if you only stare at body weight. And testosterone is not a diabetes treatment. This is worth saying clearly because people blend these ideas together. Improvements in body composition do not automatically translate into meaningful improvement in blood sugar control or diabetes prevention. Large recent datasets make that point pretty clearly. So, if you have pre-diabetes or type 2 diabetes, that still needs dedicated metabolic care. Treat the testosterone deficiency if it is real, but do not pretend it replaces the rest of the plan. Bone is the long horizon. If a man has severe hypogonadism, a history of fragility fracture, osteopenia, osteoporosis, or diabetes that raises bone concerns, then a baseline DEXA can be appropriate. If you are monitoring bone, the repeat scan generally makes sense at 18 to 24 months when clinically indicated. Bone is slow. An early scan tells you almost nothing about short-term treatment success. Now let's talk about labs, because this is the part people often treat like paperwork. Follow-up labs answer 3 questions. Is the treatment producing the expected biochemical response? Is it safe? And does the lab change match the symptom change? At Vidma, we check follow-up labs after the first month, formally reassess efficacy and safety at 3 months, and then monitor every 6 months. That cadence matters, early enough to catch problems, long enough to see a real trend. Our men's health panel includes total testosterone by LC-MS-MS, free testosterone by equilibrium dialysis with LC-MS-MS, LH, FSH, estradiol, CBC, comprehensive metabolic panel, vitamin D, PSA if you are 40 or older, and insulin if BMI is over 25. When the clinical story calls for it, we may also look at a lipid panel, prolactin, or TSH. That is part of a real diagnostic workup, not a gimmick. For men on enclomiphene, LH and testosterone are especially useful because we expect the axis to respond. If LH and testosterone are not moving, something is off. For men discussing TRT in a general educational sense, hematocrit becomes especially important because elevated hematocrit is the most common treatment-related adverse effect, and it often shows up between 3 and 12 months. That is why ongoing monitoring is not optional. I had a patient not long ago who felt a little better subjectively after starting treatment elsewhere, mostly because he was sleeping better and paying more attention to his health. His testosterone level, though, had barely changed, and nobody had checked the basics carefully. That's a good example of why symptoms without biochemical confirmation can be misleading. The reverse is also true. If the lab looks better but the man feels no meaningful benefit, you may not be treating the right problem. The formal 3-month check is where the story comes together. Are libido and erections improving? Is energy meaningfully better? Is hematocrit safe? Has blood pressure changed? Is waist circumference moving? Do the labs match the expectation for the treatment you chose? If the answer is no, you do not just shrug and keep going forever. When progress stalls, interpretation matters more than optimism. If testosterone has not moved into a therapeutic range by the first reassessment, symptom improvement is less likely. If sexual symptoms have not improved by 3 to 6 months despite therapeutic testosterone levels, I start looking beyond hormones. Vascular disease, neurologic issues, medication side effects, relationship stress, sleep, performance anxiety, all the usual suspects. A lot of men hear low T and think every problem below the neck must be caused by low T. Convenient theory, often incomplete. If mood has not improved after hormone levels normalize, again, widen the lens. Testosterone can help selected men with depressive symptoms. It is not a substitute for psychiatric care when a primary mood disorder is driving the picture. And if the original workup did not include LH and FSH, go back and fix that omission. Without them, you never truly knew whether the man had primary hypogonadism, which pushes you toward replacement, or secondary hypogonadism, which makes enclomiphene the more rational first-line option when LH is below 8. That distinction is not academic. It changes fertility, safety, and what success should look like. It also changes how you think about long-term safety. The best modern evidence we have, especially from the Traverse trial in more than 5,000 men followed for about 33 months, showed TRT was non-inferior to placebo for major cardiovascular events when used appropriately in men with documented hypogonadism. That is reassuring. It also did not show an increased prostate cancer risk in that trial, but reassuring does not mean casual. TRT still requires monitoring. Safety is something you verify over time, not something you assume because a headline sounded positive. Common questions come up in clinic all the time, so let me answer a few directly. A lot of guys hear that testosterone levels can change quickly and think they should feel dramatically different in a week. Usually not. Blood levels and body experience are not the same thing. TRT may normalize serum testosterone quickly, but sexual symptoms often improve most clearly by around 3 months. Enclomiphene can raise LH and testosterone within 1 to 2 weeks, but we still judge the real clinical response over the next several weeks and confirm it with follow-up labs. Another one. If I lost a little weight, that means my blood sugar is fixed too. No. Better body composition is good. It is not the same as treating diabetes. Those are related but separate outcomes. Another. My erections are still inconsistent, so I must need more testosterone. Maybe. Often no. If testosterone is already in range and erections are still unreliable, the next step is not always a bigger dose. Sometimes the right move is to evaluate blood flow, medications, sleep, stress, pelvic factors, or add a targeted medication like tadalafil when appropriate. And one more, because this one causes a lot of regret. I'm not trying for kids now, so fertility can wait. I would not take that lightly. If future fertility matters to you, discuss it before treatment starts, not after 6 months or 2 years of suppressive therapy. So if you want the practical version of all this, keep these steps in mind. First, confirm the diagnosis properly. Morning labs, persistent symptoms, total testosterone and direct free testosterone, LH and FSH every time at baseline. If those are missing, you are not done. Second, classify the problem before choosing treatment. High LH plus low testosterone suggests primary hypogonadism, where TRT may be necessary. Low or normal LH plus low testosterone suggests secondary hypogonadism. If LH is below 8 and the axis is intact, enclomiphene is usually the smarter first-line option, especially if fertility matters. Third, measure progress on a schedule. First month labs, formal 3-month reassessment, then every 6 months. Watch symptoms and safety together. Do not make decisions from vibes alone. Fourth, track the right outcomes. Libido and morning erections may improve first. Mood may improve modestly. Body composition takes longer. Use waist circumference, workout recovery, and sexual function, not just the scale or a single good day. Next time, we'll get into living with low testosterone, long-term management, and outcomes. Make sure you're subscribed so you don't miss it. If you've been feeling low energy or brain fog, poor sleep, low mood or motivation, weaker workouts or recovery, reduced libido or sexual performance, or unwanted body composition changes, and that sounds like you, upload your labs to Vidma for free or order labs through our special offer at vidma.com.